Lovely. So welcome to the session, everybody. My name's Lou. It's an absolute pleasure to welcome Dr. Komal Bajaj, who is an innovator, catalyst and advocate in the Bronx, New York. She is also the Chief Quality Officer for New York City Health and Hospitals Jacobi and the Clinical Director for Simulation within the health system. So we're really excited to have her with us this afternoon. Thank you, Komal.
Thank you so much, Lou, and great to be here with the Fab Change community of practice. So I'd like to tell you a little bit about Sam. It's Sam's first day after orientation, and he is really excited. He's dreamed about being a part of healthcare delivery for a long time, and he's worked really hard to get there. He spends most of the morning trying to remember people's names and researching the rare diagnosis one of his patients has. Unfortunately, there just isn't much out there. He also spends 1 solid hour trying to decipher the hospital's transfusion protocols, which don't look like anything he's ever read before in a textbook or online. By 1:30 p.m., his stomach is growling, and as he takes a break to try to figure out where to get some food, his phone rings. It's the head of the research team asking if now is an okay time to approach one of Sam's patients to enroll them in a study on effective patient education modalities. We need to get our numbers up before enrollment ends next week, she says. Sam feels like it would be better to wait, but he's not sure how the research director will take it if he asks to delay. It's fine to say come back later, or is it? Whew. Sam's morning sounds very similar to my first day, and uncertainty like the kind Sam and so many of us have experienced has been acknowledged as a challenge in healthcare for decades. The literature is ripe with examples of how uncertainty manifests in a variety of healthcare settings and has real consequences for decision-making, quality of care, training outcomes, as well as staff and patient engagement. Identifying different types of uncertainty helps acknowledge its presence and subsequently develop solutions to really manage that uncertainty. One model of uncertainty suggests that uncertainty spans 3 overlapping domains: personal, practical, and scientific. Personal, practical, and scientific. Personal uncertainty includes psychosocial, ethical, and existential uncertainty. Will I survive this? Am I doing what is right? Was that interaction I just had a healthy one? Sam's grumbling stomach and his reaction regarding the research director fall into this domain. The second is practical, the uncertainty of structures and processes, how we get stuff done, and how those structures and processes interact with one another. The blood bank protocol is just one manifestation of the many uncertainties that Sam undoubtedly faced that morning. Scientific is related to diagnostic, prognostic, and treatment uncertainty. The rare diagnosis that one of Sam's patients has brings uncertainty on how best to counsel and treat the patient, truly challenging for both patient and healthcare team, whose mutual goal is to get the patient back home safely. The COVID-19 pandemic is a true exemplar of these overlapping domains of uncertainty. As Professor Tricia Greenhalgh and colleagues have put it, the COVID-19 pandemic is a complex problem in a complex system. As the COVID-19 pandemic continues to mature, uncertainties continue to multiply. Are reopened schools safe? What's the best way to address the long-term health sequelae of this virus? What multifaceted solutions must we put in place to address the injustices that have so sharply been brought to focus during this time? I am privileged to be a healthcare quality leader in the Bronx, New York. And the trauma center that I serve here in the Bronx is one of 11 acute care facilities for New York City Health and Hospitals, which is the largest municipal health system in the United States. And so just to give you kind of a sense of scale, here are some of the larger facilities that are distributed across all of the 5 boroughs. And as you can see here, we have on the order of 42,000 employees, a little under 16,000 births per year. So quite a large health system. Like all of you, we have faced and continue to face much uncertainty here in New York as we deliver care. And I'd like to share with you 3 examples of how we drew from contemporary quality improvement techniques, including simulation, to address uncertainty during the peak of the COVID-19 surge in New York City, which began in March of 2020. The first I'd like to talk about is the establishment of a safety spotter program as a way of mitigating uncertainty. During the care of patients with special pathogens, trained observers have often been used to assist healthcare teams by proactively identifying safety threats and assisting in safe personal protective equipment use. We are fortunate to belong to NETAC, which is the National Emerging Special Pathogens Training and Education Center, or one of a handful of centers across the United States that are part of this collaborative. We cared for a patient in our health system who had Ebola, and since 2014, we've been using simulation quite extensively to prepare for special pathogens. Here's a little screenshot of me debriefing a healthcare team who had just cared for a patient with Ebola and had the challenging task of cleaning up a spill. And so we used simulation to train 32 observers in PPE use. And we really drew these safety spotters from areas that naturally had been decreased volume. So things like the OR, so OR techs, or our dental clinics, like dental hygienists, not just because those areas had decreased volume, but because those individuals tend to be naturally facile with PPE based on what they do. The simulations were low tech, using PPE that would be actually used in the clinical environment, and were conducted either in the clinical unit themselves or just outside in the hallways. These spotters were assigned to 10 COVID units, and their function was really to assist with PPE, perform just-in-time coaching, and maintain situational awareness. As guidance changed, we continually retrained the spotters, who in turn helped retrain our staff. Just as we heard earlier today, a wonderful presentation by Dr. Mountford. The NHS Nightingale COVID Hospital published its experience implementing learning systems, including a bedside learning coordinator, whose function was to make observations in almost real time and collate suggestions daily. Similarly, we collated feedback from these eyes and ears on the units about PPE challenges and other opportunities for safety and flow optimization. These were collated, addressed using rapid tests of change, and looped back with staff. One optimization was a series of PPE tips based on common challenges that were identified. What you see here, for example, is a tip that was developed after spotters saw staff in multiple areas touching their masks during removal. The tip prompts staff to remove their masks from the straps, an area that's less likely to be contaminated. This tips resource was shared with the rest of the system, and the nature of the tips evolved as staff became more comfortable with PPE. Based on staff feedback about how much safer they felt with the spotters in place, as well as our staff rates of infection and antibody seroconversion, we believe that this program did help decrease the practical and personal uncertainty of our staff and keep them safe. While I definitely hope we don't have to redeploy such a program, we certainly have the machinery and expertise to do so if needed. The second example I'd like to talk about related to mitigating uncertainty is specifically tied to staff support and wellness, which I know is a key theme at the conference. The well-being of our staff has been a key priority for our health system long before the pandemic, and our system's quality leadership had to quickly adapt operations to mobilize additional resources during the surge for staff support. Beyond some sort of choice four-letter words, there were a lot of feelings and sentiments and real challenges and personal uncertainty that were identified. The first being, schools are closed. What am I going to do? I face this myself with my almost 7-year-old twins. And so the health system established quality childcare free of charge to children of the health system. And more than 1,500 children of the health system were cared for during this time by that resource. A second common sentiment was, I don't want to bring this virus home. New York City is often a big hub for tourism, and certainly hotels were empty during this time, and temporary lodging was made available through negotiated agreements with nearby hotels free of charge. More than 2,300 staff used this program in March and April of 2020 alone, mitigating the real uncertainty of how to safely physically distance from those that they lived with. A third common sentiment was, where can I get fresh, healthy meals right now? A lot of the restaurants and places to order from or get groceries from even were limited or shut down completely. With philanthropic support, the health system was able to provide free meals for workers during shifts. Where to put the signage, how to safely distribute meals was simulated just prior to the arrival of these gigantic food trucks on our campus. We were fortunate to have a substantial number of armed service members join our teams. And here you can see two of those members poised and ready to hand out these meals. And it was really marvelous choreography to see hundreds of meals coming in and hundreds of meals going out. Addressing uncertainty around basic needs such as childcare, food, and shelter was crucial to staff well-being. We also directly address the emotional needs of our staff by harnessing our existing peer support second victim program, what we call Helping Healers Heal, or H3. Dozens of peer support champions and behavioral health providers in the Bronx-based hospital that I serve, who had received simulation-based debriefing training, visited every clinical and non-clinical area of the hospital. Here you can see so that rowdy bunch, including on the left hand, a goofball character, namely me. And I'm really proud to say that we've been able to check in on every staff member, regardless of tour or profession, at least once during and immediately after the surge, including areas that sometimes might be forgotten, like parking valet or food services. What a scary feeling to be coming in and out of healthcare workers' cars every day. And so, we, as a result of this program, a little under 2% of our staff have needed to escalate to tertiary level care, such as social work, psychologists, therapists. And, we're really proud of that because it's taken mental health of healthcare workers out of the shadows. And many staff have expressed trepidation about the unknowns ahead. And our peer support team will be one way in which we embrace and address those uncertainties. The third I'd like to talk about relates to enhancing communication as a way of mitigating uncertainty. Have to say, communicating updates in ways that are timely and reach people that they need to reach on a good day is challenging. And certainly the heightened personal, practical, and scientific of uncertainty of COVID, just as I'm sure many of you experienced, took that challenge to a new level. We used a multi-pronged approach to try to get the word out. A repository of up-to-date resources was added to the main page of our intranet site, trying to address that scientific uncertainty. Daily emails from our hospital leadership provided crucial information to our staff about, how many patients had been successfully discharged, what were the new areas of the hospital that we had flexed and surged into ICU level care. We also took to using the flat screens that typically contain patient education information for regular updates. Here's one of our awesome healthcare team members stationed at one of our entrances, and as you can see, there's a PPE tip that's on the flat screen behind her. As we push past this initial surge, we must contemplate what quality and safety initiatives make sense, while also maintaining vigilance for a rising now, in-sight second wave of COVID-19 cases. This post-surge pre-resolution phase necessitates a new way of thinking, where we'll really honor the tremendous psychosocial impact of the pandemic and harness the really nuggets and beautiful lessons learned from our experience. One approach to mitigate the parallel pandemic is to ensure that quality and safety initiatives explicitly promote psychological safety and empathy, two foundational elements of mitigating uncertainty. This prioritization matrix that we developed tightly links psychological safety and empathy with the more traditional goal of maximal clinical operational benefit. Using this matrix can help identify the must-do quality and safety initiatives that both strongly promote psychological safety and empathy and have substantial clinical and operational benefit. Despite all our efforts with communication, one project that we have been very actively working on in the must-do category is to enhance bidirectional communication. We have actively sought out feedback from staff on what went well and what to change for the future. We've shared our after-action review with our staff. And have identified some solutions that we're actively trialing to see whether they should be hardwired for the future pandemic or not. And, we recently wrote about, where healthcare quality is going to be in New York City health and hospitals in this publication in Health Security. And as you can see, priority number 1 is a focus on psychological safety. Number 2 is to reprioritize quality improvement activities. I think all of us, in end of 2019 or early 2020 developed sort of agenda for quality in the subsequent year. And those beautiful, I was looking at our plan a few days ago, and which sort of beautifully needs to be put on a shelf as we reprioritize what makes sense in this unique time. A priority 3 for us is to modify quality reporting and management activities, recognizing that the burden of data collection and just some of the priorities have shifted. And so, from board level down, acknowledging that we need to look at measures that make sense for right now, and sort of modifying that activity. And the last, we had a strong emphasis on quality improvement capacity building before the pandemic, and recognizing that, I think Dr. Mountford said it, that, this pandemic made improvers out of all of us. We want to make sure that that sticks, post-pandemic, and that people have agency, the power and courage to really affect change in their environment. So we will continue to we will resume and have actually resumed virtually those quality improvement capacity building activities. So uncertainty has been and will continue to be a feature of healthcare long after this pandemic has subsided. And I urge each of you to consider 3 ways to address uncertainty. First, embrace it, hug it. It's going to be with us. Naming it, acknowledging its existence, and the various ways it makes us feel and act is crucial to managing it. And I have to tell you, sometimes that's hard. I don't like it because, it feels nice when my team and I feel like we have a handle on a situation, but it's really the right thing to do to move us forward. The second is to consider strategies that purposely address the 3 overlapping domains of uncertainty: personal, practical, scientific. Take stock of where there is opportunity in your quality improvement efforts to enhance the messaging and actions around these various elements of uncertainty. So for us, simulation has been one dynamic quality improvement technique that can be used to mitigate uncertainty quickly and effectively. The third is we live in a super connected world. Lou and I were chatting at the break about how, we've never met, but yet, we feel very connected through Twitter. 20 minutes in a space with some colleagues or on Twitter, and you can crowdsource all sorts of new ideas how to address a problem. Build interprofessional forums for discussion, collaboration, and feedback, because people are the most important healthcare resource we have. Harness their wisdom to co-create an approach to address uncertainty. There will not always be a solution to solve the uncertainty, but the crowdsourced wisdom will tell you how to embrace and message that uncertainty. Though there will always be uncertainty around us. Just want to make sure you can see me. Though there will always be uncertainty around us, I think there are a few things that I'm quite certain of. 1, my kids are super cute. Number 2, I'd really like to continue to wear yoga pants to work on occasion. And 3, we have a real opportunity not just to change how we deliver care, but how it feels to deliver that care. And I'm certain that we can, you, me, us, we, all of us together can do that. Thank you.
Thank you so much, Komal. That was really, really great. Has anyone got any questions in the chat box by any chance? Or you can unmute and ask a question if you would like. It's quiet in the chat box. Has anyone got anything they want to ask Komal while we've got her here from New York? I think I particularly liked your summary, Komal, about even in the most uncertain times, there are things that we can be certain of. And I think sometimes it's really important to remember that and to be able to have that as a grounding place that we can touch base to, and go back to, and just remind ourselves that there's always something that we do know. Somebody's put a bit more about safety spotters, please.
Yeah, Joy, I'm happy to share a little bit more. And if there's something specific you'd like to know, just go ahead and put it in the chat. So, even though the PPE that we're using, sort of in theory is PPE that folks know how to use, certainly the cognitive load of what was happening was just overwhelming. And, PPE guidance, just I imagine that it changed in the NHS, was evolving. And so we recognized that there was a real need almost to have people who were coaches around PPE. And so, the one and done training just wasn't going to work as people were sort of deluged with care for COVID patients. And it was very interesting, actually. The ICUs, the traditional where ICU care has been always delivered, were actually fine because they tended to have a cadence of and flow and knew how to use the PPE and had dealt with super infectious things. It was the other areas, the spaces that we were flexing to deliver ICU level care that needed support. And so, literally, almost from day one, the first case in New York was March 13th. And within 10 days, we had established the Safety Spotters program. And so we taught them not just sort of PPE practices and common PPE challenges, but also how to be a good just-in-time coach. And so they didn't have a clinical job on their unit. I mentioned, people like OR techs and dental hygienists, those areas had been, quickly, the volume there had completely subsided. And so these individuals then would basically just be there as a resource and roam around and help people put on their PPE, doff their PPE, be eyes and ears to watch out and say, you touch that door handle, please make sure you wipe. In this sea of gowns, we had to, mark the spotters as something different. And so we started with a different color, like a bouffant cap, but then we were running through our stock of caps so quickly that then that color needed to be used for everyone. So we started using sort of tape on the arms, marking that individual as a spotter. And I'll tell you, it took a few days for people to understand what really that role was. But by the end of it, they'd be like, hey, come over here. Can you just watch me do this? And it really sort of helped decrease the cognitive load of our staff. I'm really proud of the fact that even based on our own staff infection numbers and seropositivity, we know it made a difference.
Okay, are there any more questions? If you want to type them in the chat, if there are, is there any words of wisdom you want to share with us about anything you've not mentioned about your experiences through this, Komal?
I think that in the darkest hours, which all of us experienced at slightly different times, honestly engaging with this larger community of practice, folks around the world, from people who were still sharing, memes on Twitter about, things that were happening, or, folks that were emailing back and forth saying like, hey, I know you're in New York. How are you doing? There's so much power and value in that. And I think, one of the things for me personally that I've been thinking about is when I think of someone, rather than just like thinking of them and sending them good vibes in my mind, trying to be a little more active of just a text or a direct message, just thinking of you. And I think that, as you said, Lou, like even in such uncertain times, there are things to sort of grab onto or have a handhold on. I wonder if some of those things can be very helpful.
Thanks very much. So Matthew's written in the chat, thank you for a powerful presentation. You mentioned the overwhelming cognitive load. Has technology played a role? here? Has it been a hindrance? Could better technology, e.g. that which enables automation, help to alleviate that cognitive burden?
Yeah, Matthew, what an interesting question, and thank you for that. You know, technology in general should help our lives, and sometimes it doesn't. I think, the pandemic, in so many ways, as all of you have experienced, have sort of brought to light the cracks within the system more acutely. And I'm thinking of some of our staff who don't regularly deliver ICU level care, and then in a quick moment with some just-in-time training, we're doing some of those tasks because we were surged at multiples of capacity than we usually have. And so, the technology component, the same wishes that I have if our technologies could all talk to each other, right? If the pump and the EHR and the this and the that were all sort of truly aligned, would that have decreased the cognitive load? Absolutely, especially for those individuals who were really, so generous in flexing their own skills in the middle of this, peak wave. So I think your point is well taken. That technology, the automation, would have certainly helped alleviate that burden.
Thank you very much. So we have 4 minutes left, so we can finish the session early if no one's got anything else to say. So just give you a few more seconds to type into the chat if there's anything you do want to ask. Otherwise, we'll let Komal end there.
I zoomed through, it seems. And I will say this, I think the conversation around, building agency in teams and mitigating uncertainty, is continuing to evolve. And, don't hesitate to reach out via Twitter or, my email is publicly available on the hospital website. If you just Google me. I did that the other day and I was like, oh, I hadn't Googled myself in a while. And, feel free to reach out because, if one thing that we can do is, just as, people are publishing some of what they're doing, but there's so many of these like sort of details and nuances that sometimes get left out, things that may not make it a publication, but yet are important and have value. So don't hesitate to, reach out or interact. I'd also, there's a lot of wisdom in this room. I feel fortunate that I have a voice in front of you today, but it's exciting to think about, all of us sort of struggling and thinking about and solving these problems together.
Absolutely. I think you absolutely nailed that on the head. It's all about teams and community, isn't it? And I think the relationships that we build, even through events like this, maybe we'll take away new connections, but all those connections help us move forward in the work we do. Thanks ever so much, Komal. Lovely to have you.
Thank you for inviting me, and bravo to the Fab Change community. Thank you so much.
Thank you.